Hello and welcome to another video by Code Rhetoric with Tam Talk. So on today's video, I will be sharing with you some strategies and tips that I use to help me make my coding life easier. And so the area that we're going to focus on is diagnostic radiology, the external cause codes, as well as the burns. So our first strategy and tip will be focusing on the radiology section of our CPT manual or our current procedural terminology manual. So our first strategy or tip is to remember in the radiology service section that the section always starts at the top of the head and it works its way down the body to the bottom of the feet. So for example, when you're coding radiology services, the section of the radiology book is set out where, again, it starts with the CPT services and procedures. That starts again at the top of the head and it works its way down to like from the head to the neck, to the shoulder, to the arms, elbows, fingers, and so on and so on. So our next tip is you want to pay close attention to the code descriptors because some of them may have anatomical locations already embedded in the description. So yes, so this is very important. Our next strategy is you want to make sure you're able to identify if the code has contrast or if it's a code without contrast. So if it's a code with contrast, then there's no need to code an additional service of contrast or code of contrast. Or if it is without, then you want to make sure that you're selecting the appropriate code. Again, pay close attention to your code descriptions, again, because one, it may or have already include the anatomical location as well as whether or not there's contrast being utilized. And then which leads into our next strategy and tip is when reporting professional services or the professional component, the date must reflect the date that the radiologist supervised and interpreted the film. Okay, so you want to make sure the date of the charge or the date that's being reported reflects the same date that the radiologist supervised and interpreted the film. So just to recap that, so remember the radiology section of your CPT manual, it always starts at the top of the head and works its way down to the bottom of the feet. The next tip or strategy is you want to pay close attention to your code descriptors because it may include the anatomical location as well as it may include whether or not that particular radiology service includes contrast or as the book would describe it, with or without contrast. And then lastly, when reporting the professional component, the date must reflect the date that the radiologist supervised and interpreted the film. So when assigning your diagnosis code or your ICD-10 CM codes to your diagnostic radiology coding services, you want to make sure you're coding the definitive or to the highest specificity diagnosis or diagnoses. If in the event the diagnosis isn't confirmed, then you want to code the indications such as the signs or symptoms. And then you want to make sure the diagnoses are specified and again coded to the highest specificity. Secondly, modifiers. The radiology section is probably, I don't say the most heavily section where modifiers are utilized. So you want to make sure that you are assigning the appropriate modifiers and that you are assigning modifiers such as the anatomical, the component, whether it's the professional or the profi component, or the technical component, and then if it's a repeat procedure, like for example, the same providers, or if it is a different provider. Okay, so some examples of the modifiers, for example, we have modifier 26, which represents the professional component, and then modifier TC represents the technical component. And if the provider owns the equipment, modifier is not required. So again, modifier 26 represents the professional component or the physician component. Modifier TC represents the technical component or the facility component. And then again, if the provider is performing the service as well as if he or she owns the equipment, then a modifier is not required. So here we have our radiology example. We have our indication, the procedure, the findings, as well as the impression. So for your indication, this represents the reason for the x-ray, the reason why the patient is presenting for radiology services. Next, we have our procedure. This describes the x-ray or the radiology or radiological service performed. Then we have our findings. This is what is seen on the film. Do not code from the findings. There is some controversy about whether we should be coding from the findings or whether or not we should be coding from the impression. And so I recommend do not code from the findings because, again, you want to look for the impression. You want to look for the final diagnosis. And the reason why I say we do not code from the findings is because, one, we are not the radiologist. We are not the physician interpreting the service, right? So what may be found on the film is for the provider who's interpreting that film to confirm whether or not that is a final diagnosis or if it is the actual diagnosis for that patient. Are there different diagnoses or different things that are picked up in the findings? Yes. And most commonly, I won't say most commonly, but typically, if there is a diagnosis in the findings, if that provider interpreted that film correctly, or again, I'm not a provider or a physician, but if the doctor interpreted that film, that doctor is going to put that diagnosis in his or her impression. So you may see it twice. Again, we are not the providers. We are not the radiologists. Therefore, we cannot assign diagnosis to a patient, again, because we're not the provider. So again, if there are diagnoses or possible diagnoses in the findings, we want to make sure we're looking at the impression or the end result for the final diagnosis per the provider who interpreted that service or procedure. Okay, so again, we have our indications, which represents the reason for the x-ray, our procedure, which is the actual radiology service or procedure. And again, this describes the x-ray that was performed. And then our findings is what is seen on the film. Again, do not code from the findings. And then lastly, the impression, which represents the final diagnosis or the interpreted diagnosis by the rendering provider. So we're going to move into our external cause codes. So the first thing is external cause codes tells a more detailed story of what occurred with the injury. Okay, so depending on which side of the coding, I would say the coding chair, for example, if you're a facility coder, it is required that the external cause codes are assigned. If you're coding for the physician or you're a profi coder, it is not a requirement. However, it does look good because the doctor is providing a detailed background as to what caused the injury. So again, facility coder, it is required that they assign external cause codes. A profi coder, it is not a requirement, but it does provide more insight so that you can better assign your ICD-10 code. Okay. So again, the external cause codes, it provides a complete story in codes. So I have an example here for you. Oh, and one more tip. External cause codes can't be listed as your primary diagnosis or primary diagnoses. So you can't, again, assign an external cause code as your primary diagnosis code. And so the example that we have here is a 5-year-old presented to the ER with a fracture of the left pinky finger. She was trying to climb out of her high chair in the kitchen at home, and her finger was slammed in the door by an older sibling. Okay, so again, we have a 5-year-old who presented to the ER with a fracture of the left pinky finger. Again, so what happened? How did she receive this fracture? She was trying to climb out of her high chair in the kitchen at home, and her finger was slammed in the door by an older sibling. So our diagnosis that should be listed if you're on the facility side should be S62.607XA, which is an actual fracture of the pinky. The activity is whatever caused it, what caused it, right? Which is Y9 3.39 and W23.1XXA. She was in the high chair and it was slammed in the door. She climbed at the high chair and it was slammed in the door. Then you want to assign the place of occurrence, which is Y92.010. And so the external cause code is Y99.8 for facility coding. As the patient progresses through the visits, the last digit will change from A, which is this is the initial encounter for that provider. D is like the subsequent visit. And then S is the sequela. What was the end result of this injury? Like, did the patient encounter, I don't want to say endure, but did the patient develop some type of sequela diagnosis because of this fracture? So therefore, you would assign S. And again, if this is the same provider who is actually treating the fracture. So based upon the fact that the patient was seen by the emergency room physician, the emergency room physician will assign letters A to the end of the codes. Again, because this is his or her first time encountering this patient, encountering this particular injury. Whereas if the doctor refers the patient to, let's say, an orthopedic surgeon, then of course, then the orthopedic surgeon, if this is his or her first time encountering this injury, again, his diagnosis code, he probably won't do the external cause codes. He would definitely assign like the actual fracture, and then his first encounter would be with an A. So if the patient is coming back in for treatment or management of that fracture, so the next encounter where the patient shows up, like the second encounter, the orthopedic surgeon will assign the letter D to the diagnosis code, right? Which is the X62.607XA. Instead, it would be S62.607XD, because again, remember, the orthopedic surgeon had already initially saw the patient. Now the patient is in for subsequent care. And so let's say the patient developed, let's say, I'm going to say arthritis, right? I'm just pulling something out the air as a cause, or like a long, it's an injury or a diagnosis or a sequela because of that injury. So the diagnosis will become S62.607XS, because there is a sequela, right? Because this was the initial injury, this was a fracture. Then you're going to code, let's say, arthritis as the other diagnosis, because that's what ended up being the result of the pinky fracture. So, so right here you see how it progresses and how that last digit changed, right? So A is for like the beginning. The first encounter is going to be in the seventh, or yes, let's see, S62, the 8th digit, A, right? Then we're going to move from there, and the second encounter is going to be, the A is going to change to D, and then from there, then the D is going to change to S. So again, we have the initial encounter, the follow-up or the subsequent, and then the sequela. Next, we're going to move into our burn section. So burn procedures consist of debridement, dressing, eschar-otomy, the first degree, our initial treatment, if there's tissue cultures, skin grafts, and total body surface area calculation. So to calculate the total body surface area by referencing the Loon-Browder diagram located in the integumentary system of your CPT manual, as well as you can see here. So the percentage, It's based on the location and the degree of the burn. So for example, the doctor should document whether the burn in a specific location, whether it's first, second, or third degree. So we won't go too in depth into the burns. That may be another video where we can actually work on a burns case. But again, the different things that you need to look at or that consist of burn procedures are, again, the debridement, dressings, eschardomy, first degree, the initial treatment, tissue cultures, skin grafts, and the total body surface area calculation. And again, to calculate the total body surface area, you want to make sure you reference the Loom-Browder diagram located in your integumentary system of your CPT manual, or as you can see here, where it represents the percentage of each area and how that is equated, again, to help you come up with the total body surface area. So our burn ICD-10 coding guidelines is under chapter 19, which represents our injury, poisoning, and certain other consequences of external causes, which is represented in category S00 through T88. And in section D, the coding of burn and corrosions, and then it further breaks down 1 through 9 from sequencing of burn and related condition codes, all the way to the use of external cause codes with burns and corrosions. So this concludes our video on our quick tips and strategies on diagnostic radiology, external cause codes, as well as burns. So as I previously mentioned, I will probably drop a video to go into more detail about burn coding or coding of burns with a burn example. So so to get in contact with me or to find out more information about medical coding and what Abraham Medical Coding Coach has to offer, please visit our website at www.abrahammedicalcodingcoachllc.com. You can email me, and again, this is business inquiries only at abrahammedicalcodingcoach@gmail.com. And please make sure to subscribe to our YouTube channel or follow us on Instagram, Facebook, and LinkedIn. Again, it is Abraham Medical Coding Coach LLC. Thank you.